Yes, let's discuss choleasteatoma. So, what do you mean by choleasteatoma? What is this name indicate? Choleasteatoma means cholesterol plus oma means tumor, but it is a misnomer. It does not contain cholesterol or it is not a tumor. So, actually, in the middle ear cleft, we have in the anterior inferior part, we have ciliated columnar epithelium, and in the middle part we have cuboidal epithelium, and in the and in the attic region we will have pavement epithelium, which is squamous epithelium, right? What is choleasteatoma exactly? It is keratinizing squamous epithelium, and okay, means skin in wrong place actually. Okay, skin in wrong place. So in the middle ear or mastoid, if this is the type of epithelium, keratinizing squamous epithelium appears, it is choleasteatoma, right? So, choleasteatoma will have two parts. The matrix will be made up of keratinizing squamous epithelium, which is resting on the thin stroma of the fibrous tissue, and another one is keratin mass will be there in the center, which is keratin debris produced by the matrix. So, we'll also, if in the exam they give instead of choleasteatoma some epidermosis or keratoma, should not be confused, and we should write about choleasteatoma. So, see this picture. In the central, we'll have two parts we discuss. One is matrix and another one is keratin mass in the center, which is pearly appearance, and the pavement like cells which is stratified and squamous epithelium, that is matrix, and outer of it is stroma, and the whole thing is bone. Okay, so outer side of it is bone. So origin, why this is occurring? First, everything we should question why. So why, when you question, then the actual learning process will begin. That's why how various theories and various inventions occurred by the question why. Okay, so why it is happening? So one is presence of the congenital cell rest, and another thing is tympanic membrane invagination from the attic we have squamous epithelium. So if it is invading, okay, of posterior superior part of the past tense in the form of the retraction pocket, then we have now in the middle ear we have now squamous epithelium due to that invasion from the attic. Okay, so we'll have squamous epithelium. So on if that persists, it will cover itself with a keratin in that pocket. Okay, outer surface of the tympanic membrane will be normally lined by the stratified squamous epithelium, which after invagination to form the matrix, it will gather the keratin in that pocket. Okay, this is Whitmark's theory. And another thing is basal cell hyperplasia, which is Rudy's theory. Basal cells of the germinal layer of the skin, they will proliferate under some underlying infection. So, and they will also lay down the keratinizing squamous epithelium. So these are the, so this is the retraction pocket we'll see here, and this is some basal cell hyperplasia what you are seeing, and at last we'll have they are saying that epithelium invasion is occurring due to the perforation of the posterior superior part of the tympanic membrane. Through that perforation from the attic, there is an invasion, and this squamous cell is coming into the middle ear, and due to the to gather keratin in the matrix in long standing process, we will have keratin in the retraction pocket. Okay, so that's it. So first there is retraction pocket, one theory, and in another thing is basal cell hyperplasia. Okay, so next Haberman's theory. Haberman's theories will have from external ear, will have external auditory meatus, right? So epithelium from the meatus and outer drum, they will grow into the middle ear. So some perforation is there. So through the perforation, that epithelium is growing into the middle ear. Of especially of the marginal type of perforation where annulus tympanicus has been already destroyed. So through the perforation, middle ear epithelium is growing into the middle ear through the perforation. meatal epithelium. So that is leading to the choleasteatoma according to the Haberman's theory. It is known as epithelial invasion. Another thing is metaplasia. Commonly Barrett's esophagus, there is metaplasia. So what is exactly metaplasia means? Change of the epithelium. Okay, so due to some underlying cause. So in middle ear mucosa, like respiratory mucosa, everywhere elsewhere, it will undergo some metaplasia due to repeated infections and transform to squamous epithelium. Normally it should be cuboidal epithelium. It is going to transform to the squamous epithelium, right? So where else you saw squamous epithelium is converting into the columnar epithelium, means in Barrett's. Now here cuboidal epithelium is transformed into the squamous epithelium. So how do you classify choleasteatoma? You have congenital, acquired. In acquired we have acquired primary and acquired secondary. Congenital choleasteatoma, that embryonal epidermal rest of the middle ear cleft or temporal bone through this embryonic epidermal cellulus or middle ear cleft, this is arising, this congenital choleasteatoma. They have three important sites. One is middle ear and another one is petrous bone, petrous apex of the temporal bone. So petrous apex and CPA, which is cerebellar ponton angle. So depending upon the location we will have the symptoms. Okay, middle ear congenital choleasteatoma will have some tympanic membrane will be, it is congenital, right? The tympanic membrane is intact, but there is some mass behind the intact tympanic membrane, which is actually the choleasteatoma. And it will cause, why it is important means it is causing obstruction to our conduction, and it is leading to the CHL, which is conductive hearing loss, sometimes discovered on routine examination of children or at the time of the myringotomy. So it also spontaneously sometimes it rupture through the tympanic membrane, and if it gets rupture spontaneously, if it gets rupture, then there will be some leakage through the ear, means discharging ear will be present, and we should distinguish it from the CSOM. So choleasteatoma is choleasteatoma rupture, so there is a leakage here, so we should remember it, and we should not confuse with the CSOM. So next, primary acquired choleasteatoma. Primary acquired choleasteatoma, we had saw this 11.2, this is through the posterior invasion. They are saying 11.3, where it is. Okay, this is 11.3. So first, eustachian tube obstruction. There is a negative pressure creation in the middle ear. So attic or posterior superior retraction pocket will be creating. So it leads to primary acquired choleasteatoma. So sometimes proliferation of the basal layer and metaplasia of middle ear mucosa occurs due to subclinical infections of middle ear, which further leads to primary acquired choleasteatoma. So ET obstruction, due to that ET obstruction there is a negative pressure in the ear, so there is a creation of the retraction pocket, so leading to the choleasteatoma, and sometimes metaplasia of the middle ear mucosa and proliferation of basal layer also leading to the primary acquired choleasteatoma, right? So then secondary acquired choleasteatoma. So we have these three. One is invagination of the pars flaccida. Theories are invagination of the pars flaccida. It leads to the negative. Due to that negative pressure in the attic, it creates some retraction pocket which accumulates the keratin debris. When infected, the keratin mass will expand towards the middle ear. The attic perforation is a proximal end of expanding invaginating sac. Then basal cell hyperplasia, proliferation of the basal layers of the pars flaccida by subclinical infections, expanding choleasteatoma which breaks through the pars flaccida, it forms the attic perforation. And another thing is squamous metaplasia. Normal pavement epithelium will undergo the metaplasia to keratinizing squamous epithelium due to subclinical infections. So in case of the otitis media with effusion. Then secondary acquired choleasteatoma, If already pre-existing perforation is there in the past tense, needs to secondary acquired choleasteatoma associated with the posterior superior marginal perforation, sometimes large central perforation. Theories are migration of the squamous epithelium, means keratinizing squamous epithelium of the external artery canal or outer surface of the tympanic membrane is migrating through the perforation in the middle ear. The perforations involving and destroys the tympanic annulus in case of ANOM. So which leads to the growth of the squamous epithelium, and nothing in metaplasia. We had already discussed this, and expansion of choleasteatoma causing the destruction of the bone. So once this choleasteatoma entering the middle ear cleft, it invades the surrounding structures following the path of least resistance, and then by enzymatic bone destruction. Anything destructive means first it will follow least resistance path. Okay. And we'll also follow the least resistant path, right? So bone destruction, attic choleasteatoma extend backwards into aditus antrum and then to the mastoid. In this case we'll do mastoidectomy also, and downwards into the mesotympanum where it surrounds the incus or head of the malleus. Choleasteatoma has a property to destroy the bone. It may cause destruction of the ear ossicles, erosion of the bony labyrinth, sometimes facial nerve involvement will be there, sinus plate or tegment tympani, cause severe complications. Bony destruction by choleasteatoma due to the enzymes activation like N-collagenase, acid phosphatase and proteolytic enzymes which are liberated by osteoclast and mononuclear inflammatory cells associated with the choleasteatoma. Earlier theory that choleasteatoma causes destruction of bone by pressure necrosis. Okay, that's it guys. This is choleasteatoma.